Altarum's webinar on identifying the best opportunities to reduce cost and improve quality. Before we get started, I think, Jim, were you going to go over some logistics
Yes.
for the audience?
Yep. Welcome, everyone. I just want to point out a few features this afternoon's webinar interface. In the bottom left corner of your screen, there's a Q&A pod. If you have any questions during today's presentation, you can enter them here, and they will be addressed during the Q&A session after the presentation. If you would like a better look at today's presentation, you can click on the full screen icon that appears in the upper right corner of the slide presentation window. Now, a copy of today's slide presentation will be available for download. You just need to complete a short online evaluation of today's webinar at the end of the presentation. You'll be given a link. When you complete the evaluation, you'll get another link to download the file. This link will appear on the final slide of today's presentation. I hope you find today's webinar informative. Stacey, I'm turning it back to you.
Great, thank you, Jim. So we have two panelists today who will be sharing their insights on how they've been able to achieve cost and quality improvement through moving away from fee-for-service and implementing value-based payment in their organizations. My name is Stacey Eccleston. I'm with Altarum, and I'll be moderating our session today. So for today, because both our panelists will be describing their experience with the Prometheus evidence-based case rate system, or episodes of care, I'm going to start out by quickly giving you an overview of how the Prometheus analytics platform and its products help zone in on opportunities to improve both cost and quality. Lili Brillstein will then discuss her journey implementing several episodes of care at Horizon Blue Cross Blue Shield of New Jersey. There they incented providers to work together to deliver high-quality, patient-centric care. Lili is the Director of Episodes of Care for Horizon's Market Innovations team, where she's built one of the largest programs for commercially insured patients in the country. She's a passionate advocate of episodes of care strategies to successfully migrate from fee-for-service to quality and value-based models, and I'll let her share more detail about that. Jim Humphrey will then discuss Cigna's approach to engaging providers and moving them from fee-for-service to value-based payments based on the Prometheus episodes of care. Jim serves as Operations Director for Cigna Healthcare, where he directs the nationwide development and implementation of episodes of care and other specialty care collaboration programs. Jim has vast experience working in areas of contracting, network development, and managed care operations for several large payers. We hope to spend a good deal of the time at the end today to have a dialogue with Lili and Jim about their experiences, and we invite questions from you. So as we go through, feel free to type them in the box as Jim mentioned. And you'll have to excuse me, I'm kind of battling a massive cold right now, so I'm going to be taking sips of water, I think, in between. So a little bit of background on the Prometheus model that we'll be talking about today. It was developed and tested over a period of several years since 2006 with the support of several charitable health foundations: the Robert Wood Johnson Foundation, Commonwealth Fund, New York State Health Foundation, and the Colorado Health Foundation. Since 2006, the episodes themselves have been defined and further refined with the help of volunteer clinical experts that are assembled in clinical working groups that are specific to their clinical area of expertise. All the definitions for the episodes of care are available on our website through a free application program interface, or API. Altarum's software as a service, as well as several of our certified business partners, can help ease the implementation for payers and providers, looking to undertake and grow similar programs that you're going to hear about today. As far as the analytics goes, the structure on which Prometheus is built really helps one to quickly gain insights into where those leverage points are for improving both cost and quality. The model considers the total cost of care, say for a patient, and it breaks those down into the costs related to a given episode or a group of episodes, and those that are outside the episode construct. So for the episodes, the costs for the episode are broken down into costs for typical care and the cost for the potentially avoidable complications that we refer to as PACHE. So that's the gray and the red box. Provider differences in the rate of these PACHEs are a good quality indicator and have been used as such in a lot of different implementations. Provider differences in the typical care reflect provider practice differences. Both the cost for the typical care and the potentially avoidable complications can be adjusted for severity and comorbidities that exist concurrent with the episodes. The costs of the typical care then can be further broken down into core services that are generally required in the delivery of care and other relevant services, which are in turn then broken down into potentially overused services, and for that we use the Choosing Wisely metrics as a guide, or routine services that one might expect to happen in the delivery of care. In thinking specifically about a chronic care episode, for example, and in this example asthma, we can decompose the variability in the costs in that care into drivers that are related to price versus utilization. The utilization being whether it's the service mix or the volume of services that are delivered. So in this case, the analysis tells us that the arrangement should perhaps target provider practice patterns around underuse and overuse of services, because the majority of the variation here, so 66% of the variation, is caused by the volume of the services delivered rather than the prices of those services. And in particular, it's the volume of the pharmaceuticals and the professional services. Alternatively, if you were to look at the same analysis for a procedure, and in this case total knee replacement, we find that the variability is driven almost entirely by price differences in the inpatient stays, 72% in fact. And if we look at the highest cost episodes compared to the average, they had per day prices that were 70% higher, as well as having 16% more hospital days. So you can use kind of the platform, the analytic platform, to drill into what the causes of variation are, so that you can then target your interventions for those specific issues. Another important analysis that comes out of the Prometheus analytics is to evaluate provider variation on two dimensions, both the cost and the quality. So this graph shows you the risk-adjusted average costs along the X or the horizontal axis here, and the Y or the vertical axis has the risk standardized PACHE rate. So that's the rate of complications given the that particular provider's pool of patients' risk factors. So each circle in this case is a provider plotted on both their average cost and their PACHE rate. So providers that are in the upper right quadrant here have both high cost and high PACHE rates, while providers in the lower left quadrant represent providers that have both low cost and low PACHE rates, what we might consider the best performers. We're using sort of one standard deviation away from the mean in these shaded areas, so providers that are outside of the shading, the pink or the blue, depending on whether we're talking costs or quality, are really true outliers in any of these quadrants. One other feature, one other feature of the analytics is around the bundle payment implementation is the ability to create the prospective patient-specific budgets and accumulate claims to track how the actual costs compare to those budgets. So this can help ease the implementation for payers and providers and give them, the providers, the needed insight into how their patients are doing on their particular episodes. The top piece of this chart shows the cost compared to the budgets for each of 4 different patients, and then there's an interactive Gantt chart where one can drill down into the actual claims that make up the individual episode and break those into typical versus complication costs and the type of claim, whether it's inpatient or outpatient. So let me turn it over to Lili now. That was just a little bit of background on the Prometheus bundles and how they're constructed. Let me turn it over to Lili to talk about Horizon's episode of care program.
Stacey, thank you, and thanks to everybody at Altarum actually for the opportunity to do this. So I'm going to take it back just one notch to make sure. I always like to make sure that we're all sort of on the same page and everybody understands when I'm talking about episodes of care and bundle payments what I'm talking about. I think this slide actually has some animation, so let me see if that works. Oh, I love when that works. Oh, okay. Didn't quite work, but so when I talk about episodes of care, it's the value-based model that we use at Horizon and that we're talking about today that allows us to engage specialists in our strategy to migrate from fee-for-service to fee-for-value. When I think of the difference between fee-for-service and fee-for-value, including episodes, I think about fee-for-service, is where all of the focus is on one particular provider and the services he or she delivers. In fee-for-value, the focus here is on one particular patient and all of the care that's rendered to that patient across the full continuum or spectrum of care. So the visual here, the spectrum, the rainbow spectrum is meant to reflect that full continuum or the full spectrum of services. If my animation had been working properly, you would have seen those hands moving across the continuum to really sort of speak to the fact that these models are different than fee-for-service, where the provider is focused on the care that he or she is rendering. And in these models, really it's about communication, collaboration, and coordination right across the continuum. So the idea around creating an episode is we define either a diagnosis, a healthcare event, a procedure, and we sort of look at everything that happened related to that diagnosis, healthcare event, or procedure. So if you're, and it's kind of the way I think we as individual patients ourselves think about our own healthcare, right? So if you're having a surgical procedure, for example, you don't just think about what's going to happen when you're in the operating room and the surgeon is operating on you. You have to figure out that prehab where your labs are going to be done. What are the labs, radiology, who's going to do it, where will it be, what happens afterwards, who's going to take care of you, will you be home, will you be able to get to PT, and then you want to sort of also focus on that aftercare, making sure there are no infections. And so this really kind of models the way I think patients, we as patients have always thought about our own health care. It wraps everything around the particular, whatever it is, procedure, event, etc., and looks at it as a whole episode, if you will. We use the Prometheus algorithms for a lot of our episodes of care. Just very, very briefly, you'll hear in this discussion and in lots of discussions the term episodes of care and bundled payment often used interchangeably. I am pretty particular about referring to our program at Horizon as episodes versus bundles for a couple of reasons. One is most often when you hear the term bundled payment, people are referring to a prospective model where the provider is at risk. Our model is retrospective, and our providers are not at risk. It's really Horizon who holds the risk. And so that's really one of the reasons. The other reason is the goal of the value-based models is to improve quality of care, improve outcomes, and improve the patient's experience while also reducing overall and unnecessary costs. And I think when you use the term bundle payments, it doesn't sort of convey that. So I do refer to it as episodes of care, but just so that everybody understands, those two terms do get used interchangeably, and they are essentially the same kind of concept with some exceptions. So at Horizon, I hope you can see this better than I can, the current portfolio that we have is pretty broad and it's pretty deep. We began, as many organizations do, with total hip and total knee replacement back in 2010. And I think a lot of places start there because they're very, very easy to define. You know, there's a beginning and an end. There are a lot of them, a lot of procedures, and there's a lot of variation in the care and the cost of care. So they're pretty discrete and they're pretty easy to sort of work with. Once we came out of pilot mode and we had seen enough success in terms of the quality of care, in terms of patient experience and overall cost reduction, when I got to Horizon, the mandate was, you know, let's expand this now. And so my goal really was to kind of test the model in a series of different ways. So you'll see in our portfolio, we have a lot of episodes, some that are acute in nature, some are procedural, some are chronic, some are high cost, low volume, like cabbage. Some are high volume, low cost, like colonoscopy. And some are, we won't really have time to talk about a lot of the sort of nuances of some of these, but we attempt to sort of even stretch the definition and the application of the episodes of care model, which at its core is really about managing the care of patients who end up in the episode, but typically doesn't do much to determine whether or not a patient needed to be in that episode in the first place. And we have a structure set up, a financial structure in our model that allows us to sort of expand that definition a little bit, and in some cases to be able to look at not only the care of patients who are in the episode, but also to determine or incentivize the physicians to only do, for example, a C-section on a patient who is medically indicating for a C-section, or to only do a laminectomy on a patient with low back pain who might really need that rather than something less invasive. Anything more detailed on that, I think, is for a different session. I will tell you for 2018, which I don't have on here, we didn't update it yet. On January 1st, we launched a substance use disorder episode with a behavioral health component. First sort of in the country, I think, and a really interesting, exciting episode for us. We're also launching this year an AMI episode, which will be one of our first facility-based episodes. Most of our episodes in our program is focused on physicians as conductors, as I call them, of the episode. Conductors because they're orchestrating care across that continuum. And likely there will be additional episodes, but for now those are the two new ones that we're launching for 2018. So this is sort of one of my favorite slides. It's a little bit outdated, but it will make the point, I think. You know, I always talk about, or I often get asked, actually, around the country, why we have a retrospective no-risk model. Why didn't we go to a risk-based model right at the beginning? You know, and people say to me, isn't that really where all of the change occurs? And I talk always about the fact that this movement from fee-for-service into fee-for-value or fee-for-quality, as I like to think about it, is really evolutionary, and it takes time to move from one to the other, and for all of the players, the managed care organization, the physicians, you know, the facilities, to really kind of figure out how to create success in these models. They're different than fee-for-service. The whole spirit of it is different. We work collaboratively. We create the episodes collaboratively. We create collaboratively, meaning the payer and the provider. We create the quality metrics together. Everything is really done hand in hand, as opposed to fee-for-service, where everybody kind of comes to the table with their dukes up. And if we had gone originally, and there are plenty of places around the country that have tried to do this, gone right from fee-for-service to a risk-based model, the time and space to allow for that evolution to occur doesn't happen. And so there's quite a bit of failure, and because partners don't understand what they have to do, they're not working in conjunction. And so we were really determined to create this sort of no-risk environment. We were convinced that there would be success, and we've seen that. And so on this slide, what you see, and this is a slide around knee replacement. And did somebody move my slide? I actually have to even put my own glasses on to read these numbers. It's so small. But so it's knee replacement surgery. And what you see in that first bar, where it says non-EOC, and you see a blue bar. The blue bar represents the total cost of care, the total claims cost of care for the knee surgery episode. So we would simulate the full episode, as I described earlier. And for those physicians in our network who are not in the episodes of care program. And the cost of care there you'll see is about just under $31,000. The yellow zero is shared savings. In the fee-for-service model, there is no shared savings. The next line, where it says EOC, shows you the blue bar again is total cost of claims for that episode among partners in the episode program. And the yellow number in the red box represents the shared savings that was paid to the partner. Now I'll tell you, it's not the numbers here, the shared savings numbers, that are so critical, and this really reflects a mix of partners who've been in the program a long time and partners who are new. So it's kind of a blended number. But the point of this second bar is that the total cost of claims and the total cost of shared savings together is less than the total cost of care for the partners who are, or for the providers who are conducting the same services but not in the episodes program. But it's the last bar that sort of gets me completely turned on and excited, and that is, you know, it's good that I can't see if people are rolling their eyes right now. The last bar, where it says EOC inaugural, reflects our first 5 partners who were in the program in our pilot back in 2010. And what you see there is, again, the blue represents total claims cost, and the yellow numbers represents the share of savings going to the physicians. And so the total cost of claims plus the share of savings is lower among those more experienced partners because it takes time to sort of learn, understand the data, understand where the opportunities are, implement interventions to address those opportunities. And the share of savings, so together with the share of savings, the cost is lower than the full mix of episode partners, which to me makes perfect sense, again, because we're looking at the partners who've been in the longest. But the really exciting piece is that the share of savings going to the doctors is higher. So to me, this is the slide that tells the story. It's evolutionary. You do have to be patient. You know, it's very tempting, I think, to just try to move right from fee-for-service into risk-based models. There are a lot of people who will spar with me around the country about that. And I sort of stick to my guns and say, you know, we've seen tremendous success in this model. We will move to risk-based models moving forward. But when we do, our partners and we will have had enough experience in working these models without risk, without fear, and in collaboration that I do believe they will be tremendously successful as we move into places where the physicians hold risk. So this is sort of an interesting one. You know, is it worth it? You know, doing an episode of care versus a fee-for-service model. And so here's the scenario. We had one of our orthopedic partners who was doing very, very well in the program and is a very good partner. They have very excellent outcomes, quality outcomes and patient experience and overall cost. And they were looking to get an 8% increase on their fee-for-service rates, including on what we call the trigger codes, right, the surgical codes in this case. And one of the things we do in our program, you know, I say it's no risk, but maybe some would think this is a risk. We do when we contract for episodes, we do require that the partner not renegotiate their trigger codes during the 3-year period that they're in the episode or during the contract period. So this particular provider sort of threatened to leave the program if they weren't permitted to have a unit increase on those trigger codes. So we did an analysis using their historical data in the program and found that if we had given them an 8% increase on their fee-for-service rates, it would have yielded $90,000 to the practice in additional revenue versus almost $600,000, which is what they earned in shared savings as a result of their work in the program without getting an increase. So we then said, even if we looked at what would have happened, if we'd given them a 25% rate increase, and anybody on the phone who's worked in managed care for a long time knows that that's outrageous. I mean, probably 8% is outrageous, right? But we wanted to sort of, really show the point that even if we'd given them a 25% rate increase on those trigger codes, their additional income would have been just over $250,000, again, versus $600,000 that they earned as a result of the work in the episodes program. And the thing about the work in the episodes program is it's, fee-for-service, we're making payments that have nothing to do with the outcomes, how well a patient does, if they ever get better, if they have a good experience. And in the episodes and other value-based models, it's all about how well the patient does, what the experience is, and the overall cost. So I think I think it's really interesting analysis. And so I think this is my last slide. Really, the retrospective upside-only model, as we refer to it, has really allowed for a lot of success for Horizon. We do have improved quality, improved patient experience, and reduced overall costs. But the kind of big bonus, I think, is because of the spirit of the program and the collaborative nature of the program, we have significantly changed the spirit of the interactions between ourselves and our providers. They very, very often, the physicians, and we have well over 1,000 physicians in the program right now, and we have, this year we'll complete 25,000 episodes in 2018. That doesn't include episodes like substance use disorder, which will begin this year, but the first ones won't complete until 2019. So it's really changed the spirit of the interactions, and many, many times the provider partners become the ambassadors of our program. They're out there sort of, touting the benefits of this program. And for this public health heart, that feels really, really good to me. So I think that's my last slide, and so I will hand it over to Jim Humphrey at Cigna.
Thank you, Lili, and thank you, Stacey, for that introduction at the beginning of the program. Good afternoon, everybody. I'm going to go ahead and cover the why, how, and what it is and results that Cigna has seen so far for our Episodes of Care program. Of course, as you heard from Lili, we haven't been quite that far on this journey as Horizon has been, so it will be about 3 years since January, since the inception of our program. Still a little bit early to confidently state, we're seeing major changes, but I do have some results to share for you for 2015 as well as 2016. Of course, it's a journey, and as Lili points out, we're still learning a lot as we work collaboratively with our providers. And I think if I summarized everything that we've done to date, I think what most importantly it has done for us is open the door to specialist collaboration to improve that quality and cost. Cigna has embarked on many fronts to meet the provider where they're at. So as you can pick up from this slide, we've been engaged with our ACOs for quite some time. In fact, we utilize the experience across the last decade, so hard to believe, but since 2008, Cigna's been involved with ACOs across the country. And actually, we kind of lean and leverage that experience to help support our engagements with our specialist groups that we're now moving forward in the EOC space. Obviously, the whole bottom line to all this is looking at a collaborative approach to improve quality and cost, and obviously we recognize that in order to do that, you need to be able to, obviously move in a direction that meets the provider where they're at. So what does it look like? And this slide really gives you the framework of how we set this up, and obviously lots of things are attached to this, but obviously, we needed the leadership commitment and dedicated resources to really bring all of this together. If you think about Cigna as a national company, episodes certainly offer up some interesting challenges. So a few of those would be, one, build the infrastructure and processes to serve all markets, not just confined to one state or constituent. So if you look at obviously what we do in trying to roll out a program across the country, there's definitely challenges in ensuring that our markets are up to speed and understand what this program is all about. And so that nuance, as well as putting the infrastructure around the IT and information systems to support the claim flow and information back out the door, that certainly has been a great accomplishment that we've been able to secure over the last couple of years. And then certainly, as I mentioned, leaning in on market and dedicated resources to support this collaboration. So you can put it together, you can throw reports out there, but without that collaboration, without that working together piece where it takes people to meet and converse with the groups about performance, that's where we'll really begin to see some good results. So instead of like creating one team to manage and roll out the program, we need to be engaged across each and every market to take ownership of the program and certainly work with our contracted provider community. No doubt, in this national environment that I'm in, you need to stay continuously engaged with your matrix partners. A couple notes about progress to date. So as mentioned with the first slide, we've been at this since January of 2015. We're now up to, as of I think this week, 138 episodes in play as far as contracted. Again, a lot of similarities to what Lili talked about in that it's retrospective, that it's upside only gain share. But I think the experience to date has really leaned and helped us support the idea of continuous engagement so that we can improve reporting, education, and how we engage with our provider community. Obviously, one learning that I think is very pertinent to this conversation, and Stacey hit on it early on, and as did Lili, we're actually in development of some new reporting. So we've got our typical reporting that sits out there today, whether it's the summary report, the physician detail, the claim detail. We now are bringing forward kind of a look at the variations in care across pre-trigger, trigger, and post-trigger windows for each and every episode, where we can bring forward those variations and align cost opportunities, cost-saving opportunities for those providers to look at and work on. So that reporting will bring forward in a Tableau format the ability to drop further into detail to give additional insights. Obviously, insights that have actions laid upon them definitely will support provider success and improve results. Over this next year, we're going to pick up some pace on chronic episode work for 2019, and then, of course, all of this means that we want to look at enhancing our profiling, benchmarking, and obviously creating top performer benefit-driven EOC networks. So kind of taking that a little bit further, obviously we need more experience, we need provider engagement to kind of bring some of those pieces together, but definitely looking forward to rewarding those providers that obviously are engaged and want to be a part of the value-based movement. A few results to share with you guys. So these on this slide really indicate what we saw for 2015. Not much there. I just in fact got in results for 2016, which I'll verbally share with you all today. And this really represents in 2015 about 21 groups, in 2016 another 25 or so roughly. So it's limited, and then certainly you can't bank on it, but it does have some indication of some improvement. So for 2016, across all episode types, costs were reduced by 3%. Episode of care groups that earned a value-based reimbursement improved costs by 7%. Group B strep infections for OB groups improved by 18%. HIV screening improved by 7%. Orthopedic groups that earned a value-based reimbursement for hip and knee replacements reduced costs by 7%. Post-op wound infection reduced 2% across all hip and knee replacement episodes. And then groups performing colonoscopies reduced costs by 13%. So there is definitely good proof points there, proof points that we're still kind of working through to understand how those compare against groups that are not in the value-based program. So if you look at the numbers, they're strictly based on what we saw with the groups that are involved, but really want to take a closer look on how to bring that forward and compare against groups that are not involved in value-based care, because I think that's where you can pick up on some differences. In summary, I think as we see it grow, we'll continue to refine and lean on best practices to drive continued success. So as we've developed our episode program, we've actually developed clinical levers, and we're actually on a journey to create playbooks that support our episode quarterbacks in working through the episodes as they look to improve care and lower cost. And then, of course, as you think about what Lili talked about, what we have going on, pretty much all this adds up to the provider's success is truly our success. Anything we can do to leverage information to support that provider change is going to lead to results that our clients nationally are looking for. As you all well know, the healthcare costs are not sustainable, and to be involved in value-based care and be on the front end of making changes, I think what we've seen just from the engagements we've had, and of course it's not as broad as we're looking for them to be, but we're definitely seeing a lot more interest, a lot more willingness to look at information and do something about it. So very excited to be a part of this journey, and certainly, as mentioned on the front end, we're all learning together. With that, I'll turn it back over to Stacey.
Thank you, Jim and Lili. We do have one question that came in, and Lili, this came in while you were speaking, and you were on your slide showing the average costs where you had your inaugural providers. Just flip back to that slide. And I think the question, let's see if I can find that slide.
Oh, I got it.
Oh, we're doing this together. We're doing it together.
I got it.
You got it. Yeah, so actually the question is just, are these totals risk adjusted? So I think you're asking.
Yeah, so when we look at the total cost of care and the episode costs, we sort of budget at a member, not at a member-specific level, but at a practice level. So it's sort of practice-level case mix adjusted, as opposed to member-specific risk-adjusted. And I could talk sort of a bit about that, but it would probably take up more time than we have. So suffice to say that the risk adjustment is done really at a practice case mix level for the episodes.
Thank you. Another question came in, and I think this is to either or both of you. What vendors are you using at your health plan? I'm assuming that's to implement your bundle payment for your episodes.
Yep, Stacey, it's Jim, so I'll go first on that one. So we are obviously using HealthQX as our analytic vendor to support the claim bundling, if you will, to drive at what those episode budgets are. So they work closely with us using the Prometheus grouper methodology. So we have an analytics vendor, obviously, through a cloud-based approach that supports evaluating the claim cost across 90-plus episodes that we have information on. And obviously, from a contractual standpoint, as you saw from my slides, we have 13 episodes in play currently, and obviously there's more out there, but obviously we're leaning in on those that are making a difference on the front end. So definitely have that close relationship with HealthQX, which is also known as Change Healthcare, who is also part of McKesson.
So we're also using HealthQX Change Healthcare for the episodes that we have through Prometheus, and that's where we stratify our patient population, our members, based on the claims data per the Prometheus model. We also work with an organization called CODA for our oncology episodes. That's another one of our key partners that allows us to stratify our patients based on clinical criteria. If you think about episodes as having as its sort of core goal to look at like patients with like outcomes for purposes of studying variation in care and cost of care. For many of our episodes, we can get that like enough patients through our claims stratification. And when we look at things like oncology, we really can't. You can't get clinicians can't make meaningful decisions based on a patient who's identified as simply having breast cancer or lung cancer. And so we work with an organization called CODA that allows us to stratify at the sort of the biomolecular level of disease. Those are our two major partners in the episode program.
Great, thank you. Another question came in wondering about how you deal with the differences between what you're doing here in the commercial market and between the CMS-defined episodes of care.
So, CMS just came out this week with the announcement around the Advanced Bundle Payment Care Initiative. And I have to say, I like it. I was, there are still lots of questions to be answered, but in many ways it's very similar to what we're doing, with the exception being that the providers are taking on risk. It continues to be a retrospective model. It continues to sit on a fee-for-service chassis. CMS, I think, continues to take something off the top, which is different from our program. We share all of the savings. But there is downside risk, and so and that's sort of the next step for us. But I think the program looks very promising. It's a voluntary program, and I'm looking forward to seeing participating in their Q&A. I think it's next week to find out more details. But I think those partners who are in programs like the Cigna program and like the Horizon program will certainly be among the most well-qualified to succeed in the CMS Advanced BPCI and other programs.
Yeah, Stacey, I think as Jim, as Lili had pointed out, as we see CMS come back to the table to push more of the episodes of care and bundle payment programs, we'll see a lot more traction nationally as people get more comfortable with this. And certainly, definitely some differences. Historically, Cigna on the episode side has been engaged with physicians as the quarterbacks, whereas as you well know from BPCI, much of the work has been certainly focused around hospitals and their engagement with downstream providers. So Cigna is obviously interested in expanding the breadth of what we do across small groups, integrated health systems, and other opportunities where they may be, and definitely look forward to that CMS embracing of bundled payment.
Great, thank you. So I've often heard that providers need to be ready in order to make these engagements successful. I'm wondering how you went about choosing which providers you would engage with on this, and what do you feel is the most important aspect of engaging with the providers, and what does being ready mean from their perspective, do you think, to either or both of you?
So I'll jump in, Jim. So when we started our program, which was really before I was here, it was so sort of new, and we threw it out to the network of orthopedists and really took the ones who were interested to begin with.
Yeah.
And so that's sort of how we started. And as we and the thing about the program is it's extremely fluid. We talk to each other, we make changes as we collaboratively agree to. And as we began to sort of expand the program, there were a number of ways that we identified new partners and new episodes. Primarily, the first way really was we looked at partners who were in the program already and looked to see what other episodes they might qualify for. They already understood the model, and they were interested in doing others. We then tried something which I would not recommend, which was we sent out a letter really to all of our orthopedists and all of our GI, whatever specialties we had up and running, to see which of our partners might be interested. And the reason I say you might not want to do this is because the practices that have 2 episodes a year are the ones that write to you first. So I wouldn't recommend doing that. But actually, before we took that step, there were very, very deliberate reviews of practices. We looked at volume. Our analytics team was great about producing data for us. Working with our partners and producing data that showed us what the episodes looked like by provider. And so we looked at, each of the providers in each of the episodes that we had up and running, each of the episodes that we were contemplating having up and running, and each of the episodes that our providers wanted up and running, to see which were the providers that were important in terms of having lots of volume with us, were important in terms of having tremendous opportunity to improve, were important to us in that they already were doing some really good work, and we wanted to continue to extend that with them. And in terms of readiness, and I forget the word, Stacey, but readiness and leadership, people do talk about that all the time, and I think, they think it's sort of nebulous, but to me it's extremely concrete. And what readiness and leadership means is we have to have partners who are engaged, who are able to look at the data with us, understand, work with my team, with our analytics team, to understand what is the data showing. We'll work with them to identify the opportunities. We'll work with them to help figure out what are the interventions that might be effective. What have we seen in other episodes? But they're really, the episode partners in our program who have been the most successful are those who have, for example, created a team who looks at the data, and then they have a clinical team that develop interventions and protocols to help them succeed and overcome whatever the opportunities are that were identified in the episode. And that's sort of very different than the old days where many managed care companies would create data and hand it over to a provider and say, you're not meeting our metrics, and drop the data and run. Here we're really engaged. We have folks on our team, some of whom are actually, I think, on the phone, who work with our provider partners to understand the data, to understand where the opportunities are, and if the partner needs to be able to sort of take that and do something with it, and be willing to communicate it throughout their organization. One of the things that I think one of the beauties of this program is that we as a managed care organization do not prescribe how the provider takes care of their patient, what the interventions are. We share data. We work to identify what the opportunities are. But it's the providers, through those clinical leadership groups that they develop, that develop the protocols based on the data that they communicate and push down through their own organizations to create success. So I feel like I've been talking a long time. I hope that answered the question.
I think it did. Jim, did you have anything on that from the provider's perspective as to who you feel was most ready and why?
Yeah, I think much of what Lili talked about is relevant to what we've seen as well. I think it comes down to a couple things that really are important. So it's a provider group that seeks engagement, is interested in making a difference. I mean, some of this is fairly simple. Understanding the program and awareness of doing something different to improve quality and lower costs. And I think it's a new world, it's a new day, and we often talk about that these days, that both parties are open to learning. And we obviously have to continually work on that to better understand what changes need to be made, and feedback is going to be important. So as I mentioned early on, our reporting structure that we first put out is certainly not good enough, and we've got to continually improve it so that it really helps providers that are engaged with us to make a difference. So definitely it's a journey that we're both learning, and I think it's one where both sides are still getting ready to really, obviously play in the space.
Right. We also have a question here about how does pharmacy or pharmaceuticals figure into the episodes of care that you have?
So I'll take a stab at that, Lily, and then you can jump in. So we do foresee pharmacy playing a big role in specific episodes, not so much in some of the procedural episodes that we've launched to date. So we do include J-codes and relevant medical pharmaceutical costs, but nothing on the prescription side that is filled at a pharmacy yet. That is all forthcoming, and certainly working on that endeavor to bring that forward. I think it plays a big part when you're talking about some of the chronic care work that we'll be embarking on. So if you're talking about asthma or osteoarthritis or some of the other things where pharmacy is a big play, that all needs to be brought forward. But to this juncture, Cigna has not brought that forward into its episode program, but it's on the table for development.
Right. So we have a question here about, are you seeing any common practices at the provider level that you would attribute that have driven the savings that you're seeing?
So we do see a lot of common practices within our episodes. One of the things that we do in our program is we have biannual, in addition to individual meetings with our partners, we have biannual meetings with all of the partners in a particular set of bundles. So twice a year, that means we get the orthos together. Twice a year, we get the GI guys together, etc. And they share information, which is sort of interesting. But just as an example, in the, we have the most data really around our hip and knee replacement episodes. The greatest opportunities and the greatest sort of transformative work has been done in the post-acute care portion of that episode, where patients who may have gone into rehab prior are now going home and having outpatient physical therapy and rehab, not going into a SNF, for example. In a lot of the other episodes, in the pregnancy episode, we see a lot of focus. New Jersey has the highest rate of C-section in the country, believe it or not, and we see a lot of focus on sort of ensuring that the patient gets the right kind of delivery, in terms of what's medically indicated. And there are even a little bit of movement on that needle provides tremendous opportunity for improved quality of care for the mom and the baby, as well as shared savings. So we do see, we look for trends. We share the trends within the episodes, because while there may be tremendous variation, the opportunity to sort of optimize the care and the cost of care often comes from the same kinds of opportunities.
Right, and kind of thinking about the quality of care for a minute, I'm wondering how, does quality measurement explicitly or implicitly factor into this episode of care structure and payment? And kind of along those same lines, a question came in of, with so much measurement going on around, HEDIS, how are these programs coming together and incorporated together?
Yeah, so Stacey, I'll take that question to start. For us on the quality side, for each of the episodes, we've got specific metrics tied in directly to each and every episode, so they may be different. Where you, for instance, on perinatal, you may have a C-section rate. Colonoscopies may be a PAC type 1 rate. Cabbages, we may have a infection bundle rate. So different metrics for each of the episodes. That it's all obviously toll gates to effective gain sharing, and really they act as hurdles. So we measure those metrics on a quarterly basis, and depending on claim coding and frequency, PACs, readmissions, infections, there's just different things that are being measured. And certainly it's not all in be all, because in our minds probably many in the audience would attest to, that that's not the full story and not the full picture. Obviously, we'll need to move forward with non-claim-based metric reporting, and we've obviously had discussions. We've had some internal workings on coming up with something that would obviously help us with the episode work. But again, going back to the question, I think it's very key to standardizing where we can, lean on measures that others are using, and get away from trying to come up with new measures that become administrative a nightmare for practices. So really try to keep things as tight and small as we can, and things that are meaningful.
Yeah, so we have a very similar philosophy at Horizon. We, as opposed to focusing on dozens of process measures, we really focus on outcomes measures, and we have a handful of standard metrics that we look at across all of our episodes, like all-cause readmissions, extended use of opioids after surgeries, ER visits, things like that. And then we have episode-specific metrics, that might be like adenoma detection rate in colonoscopy, C-section rate in pregnancy, things like that. And again, we develop them in conjunction with our partners, and our partners don't just include our physicians, but they include our in-house HEDIS and quality teams. So we'll look for to see if we can help with the HEDIS metrics by incorporating them into the episodes metrics. But exactly as Jim said, one of the mantras is don't make it more complicated for our providers. And don't make it more complicated for us. We want to be able to look at the outcomes measures, tie those to incentives, and just to give you a sense, when I first got here, when we were coming out of pilot, and when you're in pilot mode, you have to sort of be at a more micro level. We had over 200 data elements that we were looking at for every patient on every episode. I think every time the patient ever got touched, we knew about it. But as we sort of matured and grew in the program, we began to focus really just on outcomes, and to standardize it, to look for things that were meaningful. We look to our partners to help us identify what's meaningful in this episode. What should we be looking at? What are the proper sort of outcomes metrics we should be focused on?
Thank you. So we're coming up at the end of the hour. There were a couple of additional questions that we can try and answer for you offline, and then send you an answer to, if you will, if you want to send those to. I have Bill Hicks' email address up here right now. Also, Jim or Bill, did you want to talk about the post-webinar evaluation and the slides, obtaining the slides?
No, other than just, as you said, if you go and fill out the survey evaluation, you should be able to download a copy of the presentation. And as Stacey, if you have any other specific questions, please email me at williamhicks@altarum.org, and I'll be happy to follow up with you.
Great. We thank you all for joining us today.
Yes.